Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
We have next. These guys are so well trained. They all have PhDs. I think I like. I want to shout out to all our folks from Brazil. We have so many people watching from Brazil right now. I see you. I hear you. I've been to Santarém. I've been to the Amazon before, and I love Brazil. The only place I didn't go to was Rio and Sao Paulo. I know that Dr. Mendoza is going to take me there very soon.
I've never been to Rio either. Don't worry, don't feel bad for that. I've been to São Paulo several times, but never been to Rio.
Okay, no problem. Anyway, we have our next speaker here, also from Brazil, Dr. Rafael Sequeira. Are you here, Dr. Rafael? I know you have been
eating. Here, Dr. Uvo. Can you hear me?
Awesome. So I'm just going to read out we're going to move on to his section now. Dr. Rafael is a graduate postdoctoral resident. I think you've graduated now, right?
No, I'm in the third year of the period.
Okay, so he's a graduate postdoctoral resident at the University of Michigan, and he earned his Doctor of Dental Surgery at the University of Pernambuco in Brazil. He received a certificate of specialist in periodontics by the Brazilian Military Academy. He later obtained a master's degree in oral sciences implantology from Curitiba in Brazil, and a PhD in oral sciences from the Federal University of Pernambuco, same in Brazil. During this part of his PhD, he worked as a research fellow in 2017 at the University of Michigan in the perio department. Before joining the University of Michigan, he worked in private practice, focusing on implant-related procedures, and he held a teaching position at Facipe College in Brazil, and he also did a specialization course in Tavares Vieira Institute in Brazil. Dr. Rafael Sequeira, it's a pleasure to have you in our dental webinar series today. Please take it away.
Good morning, everyone. Thank you so much, Dr. Uvo, for this kind introduction and for the invitation. I would like to congratulate you first for doing this. It has really been great. I have been following some of the lectures before, and I was impressed with the high quality of the presentations and the participation. And it's really special for me. I'm really looking forward to that because we have participated of a few seminars before, especially during those 3 months, right? We are pretty much at home, away from the school. But this is really the first time I'm going to talk and I'm going to share a little bit of what we do with the main audience in Africa. So it's really special. Thank you for this opportunity. And without much further ado, let me try to share my screen. Please let me know if you can see it.
Yes, good. Very good.
Okay, so thank you so much. So we'll be sharing a little bit of what we do regarding the key factors for successful immediate implant placement in the aesthetic zone. And also, I would like to congratulate Dr. Mendoza for the beautiful presentation he just did before. And we have been working together, and you're going to see cases here that I worked with Dr. Mendoza as well, either on treatment planning or having him as part of the team to restore implants. So we know, let me see if I can advance, okay. We know that tooth extraction, unfortunately, is a common thing, right? Due to a disease process or sometimes to a trauma process. And many times we ask the very tricky question, when is the most appropriate time to intervene? Am I gonna place my implant immediately after the tooth extraction? Or am I gonna do any sort of alveolar ridge preservation and going for the implant placement a few months later? Or we even have other options after the tooth extraction as the early implant placement. So you wait just a couple of weeks, 4 to 8 weeks, and then you go there and place your implant after the soft tissue heal. You can go after 3-4 months with only partial bone healing, or you can wait much more time, over 4 months, to have the complete bone healing to place your implant. So today we're going to be focusing on the immediate implant placement, which happens right away you have the tooth extracted. So you extract your tooth, you go there and you place your implant. This is a very popular option nowadays to replace missing teeth. And if we go to the literature, or if we go see lectures, presentations in many meetings, a lot of people will talk about the advantages of choosing this option. And some of them are, you can reduce the number of surgical interventions and then the total treatment time. You can possibly minimize bone resorption by maintaining the periodontal architecture. We're going to talk a little bit about this. It's quite controversial. We can have better aesthetic results as well, which is also a little bit controversial, and you're going to discuss it. And we can increase the patient satisfaction. So since the first really studies in 1998 by Peter Worley till nowadays, so over 20 years, we can discuss many of those aspects and those advantages. So as you can see in the video, this is a very popular strategy to replacing a missing tooth, where we place an implant. Many times we do additional procedures as soft tissue grafting or bone grafting, and then also in some situations we perform the immediate provisionalization right away. And this will be my main focus today: immediate implant with immediate provisionalization, to try to increase patient satisfaction and to deliver a very good aesthetic outcome. But I have to be honest, and there are a number of disadvantages related to this technique as well. We are going to see that in the literature. Some papers, some publications showing lower implant survival rates for immediate implant placement when we compare to delayed implant placements in healed alveolar ridges. Some marginal bone loss can occur as well when we do this, this approach, this modality. And the changes affecting the peri-implant soft tissues, and it requires a skilled operator. So sometimes if we are really in the beginning, if we don't have much experience, if we are still developing our skills, it may be easier and safer to go for a delayed approach, wait the bone to form, to heal, and go there and place our implant instead of going immediately. Looking at the literature, this is a very good systematic review, recent published in 2019, just last year, because it's a very common question, especially from dental students. They often ask, okay, if I go and I place my implant right away, if you place your implant right away and you put a provisional on that, am I going to lose the implant because I'm going to have occlusal loading, I'm going to have forces, and I learned that the implant should be stable and without any sort of micro movement in the bone. So this publication shows, including 8 clinical trials, that yes, immediate implant placement does present a higher failure rate compared to delayed implant placement. So we see here a 5% compared to 1% to delayed. So we could say that immediate implant placement can provide us 5 times more chances for failure than delayed implant placement. However, when we go to the paper, which is well conducted, this review, we see that there is a heterogeneity in the studies. So some of the studies, they included smokers, different number of patients, the socket, some of them, they had a complete or incomplete buccal bone wall. Some cases had a thin phenotype and some have not. So there are many confounding factors that can lead to a outcome like this. So when we talk with someone, for example, that mentioned, oh, I don't have 5% of failure in my practice. I do immediate implant, I do immediate loading like every day in my daily practice, and I have a much higher success rate. So we can discuss on some of those aspects that we can control in order to achieve a higher success rate or survival rate. And if we look at those papers, these factors associated with early implant failures, because most of the failures that happened, they occur early, they are related to implant stability or the lack actually of implant stability. They are related to an infectious process or sometimes to the occlusal loading that was not controlled. And then if we discuss those three topics first, we know that we can control really well the implant stability if we do have an adequate bone quantity and bone quality. So a proper case selection is really key when we are dealing with a immediate implant placement protocol. Okay, so it's not that immediate implant placement is better than delayed or delay is better than immediate or early. I think there is an indication for each one of these strategies. We can control our drilling protocol, and sometimes we are going to drill a much narrow osteotomy bed for our implant. So we are going to under-prepare the site for the implant in order to achieve a higher primary stability. And also we can choose a length of implant, a diameter, and an implant geometry especially that can give us a better outcome in terms of primary stability. And we know, for example, that taper implants, they function much better in terms of stability when we compare to cylindrical implants. Also, another discussion that we can have is the site infected or non-infected before I place my implant, before I do the extraction even, and I'm gonna place the implant? Because we know that there is a risk of my microbial interference that may inhibit the osseointegration process and lead to the implant failure. But when we go to the literature, it's quite controversial, the outcomes. I brought to share with you two different studies. One was a systematic review with a meta-analysis, the one on here on the hand left side, where they conclude that immediate implant placement can increase the risk of implant failure in infected sockets. However, they mentioned that all the studies had a short follow-up period and a number of confounding factors. So this meta-analysis from 2016 was quite inconclusive. We have another study from a group from Italy that looking at 369 patients with 527 implants. They saw a very similar survival rate for immediate implants placed in non-infected compared to infected sites. And then they concluded that placement of implants into periodontally or endodontically infected sites immediately after the tooth extraction is a safe option, even if the implants are loaded immediately or early. So what we can conclude from the literature that is quite controversial, and what do we do in our daily practice, and what is my opinion? I think it's more important in terms of if you have a tooth that has a periodontal, a periapical radiolucency, a possible periodontal cyst, or endodontic abscess, or anything like that, the question that you have to make yourself is, even if I extract this tooth and I really can curate and degranulate all the infected tissue and have only a good bone to place my implant, am I going to achieve primary stability? So if I can achieve primary stability after a good debridement, I would go for immediate implant placement. But many times we start a antibiotic therapy at least 3 days before, many times 5 days before, to reduce the bacterial load. If you're not really sure that you can remove all the content, all the granulated tissue, all the infected tissue, because you don't have a good access, it's better not to place the implant and delay your approach. Also, the third topic that I'm going to mention regarding the early failures that are really related to the survival rates is the increased risk for the implant loss when you load it, when you put a provisional immediately, right, at the same procedure, or right, like 1 or 2 days before you place your implant. So this consensus review published recently in the clinical oral implants research, they mentioned that there is no increased risk for implant loss when we are dealing with immediate loaded full arch reconstructions or mandibular overdentures. Why? Because we are splitting the forces, we are distributing the forces in many implants. But there is an increased risk for implant loss in partially edentulous or in single tooth restorations. So in those cases, we have to be really, really careful. And when I'm gonna discuss about the restorative aspect and how we do it, you really have to control the occlusion, and how Dr. Mendonça just mentioned a couple minutes before, you have to really take it out of occlusion and educate your patient in order not to have any excess of forces that can compromise the osseointegration in the first few months. But what I really want to discuss with you today and share, and it's really the focus of our presentation and even the title, is we're going to go a step further, and instead of being discussing in detail the survival, the osseointegration, and the function, we're going to discuss more the key factors for the long-term tissue stability. And the long-term tissue stability is related to a peri-implant health, so a healthy implant, this is our goal, of course in function and with good aesthetics in order to have a very satisfied patient, right? And when we are dealing with immediate implant placement, especially in the aesthetic zone, we are really, our big fear, we are really scared of the remodeling process that this bone is going to undergo. We know that we only have alveolar bone because the teeth are there. Once we lose a tooth, the alveolar bone tends to resorb. And many times we have a resorption that can compromise not only aesthetics, but can compromise our implant position. And then imagine, for example, in this case, if I place the implant right away, immediately, and I have this sort of remodeling, this can really compromise and can expose my implant to the soft tissue and increase the risk, for example, of a peri-implantitis, of a peri-implant disease later on. So the animal studies, this is one of the most cited articles in the periodontal implant dentistry literature by a Brazilian group with Dr. Lindy from Sweden, published in 2005. They showed histology in dogs that when you have the tooth extracted from this first picture, this first histology here on the left side, until 4, 8, and 12 weeks, we have a significant reduction of the bone, especially in the buccal bone. So here on B, we have the buccal bone, the bone marrow, and then the lingual bone. So we have really a significant reduction of the buccal bone height and many times of the thickness that can compromise our implant that we are placing immediately. And we have also a recent study, a more recent study, showing a tomographic one using CBCT to show that when we have a thin phenotype, so when we have a very thin buccal bone around our tooth and we do the extraction, we tend to lose much more bone compared when we have a thick phenotype. So if you have a thick phenotype, a thick buccal bone, a thick soft tissue, you are less prone to have bone remodeling. And those are the cases that you are safer to perform immediate implant placement. In thin phenotype cases, you have to be really careful because the remodeling that you're going to have in the bone can really compromise your outcome. Then with this brief introduction and discussion of the aspects that impair the survival rate, I want to go over those 5 topics. Of course, we have many more topics that can influence the tissue stability in the long term. However, due to a matter of time, we are going to focus on those 5, which I think they are the most important ones. And why do I want to do that? Because many times in the daily practice, we do perform immediate implant placement with provisionalization. And then we follow up those cases. This is a case that the patient had an immediate implant to restore the number 7, or the upper lateral, right lateral incisor. We follow for 2 years, 4 years, and 6 years this patient. In the first few years, you don't see many changes. Here, it's 9 years after, patient still really happy, and I would say that a very reasonable aesthetic outcome. And here, 11 years after, just in 2018, before I moved to the US, I could see this patient for another follow-up. And we can see that unless it's behaving well and patient still satisfied, we can see tissue changes with time. Peri-implant tissue, some soft tissue contraction in the horizontal dimension, and a little bit of papilla loss and recession in the adjacent teeth. This implant was not placed by me. This implant was placed by a doctor that I used to work with back in Brazil. It was placed almost 13 years ago. I have this follow-up from 2018. And at that time, he placed the implant and he didn't do any additional procedure, because back in 2006, 2007, we dentists were really starting to use this type of protocol and to try to understand all this tissue healing and the peri-implant tissue changes around the tooth. I think nowadays we have strategies to further improve those outcomes. Then implant position is really key when we are dealing with immediate implant placement. And we're going to see in the literature, you're going to see many presentations and lectures from the most important speakers in the podium, that most all of them are going to converge to an idea that the implant should be placed palatally, the more palatally you can, so you avoid touching the buccal bone, and you also have a gap between your implant and your buccal bone in order that you can kind of reconstruct and place bone there. Or even if anything goes wrong, you can always have the chance to do soft tissue grafting or bone grafting in order to increase. You should really avoid to place your implant facially, buccally, because you can have increased bone resorption, buccal bone resorption, and you can really compromise your outcome. And if the bone is outside the envelope of the adjacent crowns and the adjacent bone, you are really limited in any kind of reconstruction, any kind of procedure you can do later on. Also, the apical coronal position of at least 3 millimeters. I like to work with 4 millimeters to have a good running room, a good room for my abutment and for my crown, my emergence profile. And we know that the supracrestal tissues heights on implants are, or biological width, are a little higher than on tooth. So I like to work with a 4 millimeter threshold for that. And this implant position is really gonna dictate the shape of your crown and your emergence profile. So if you look at this little video here that I made, any difference, any changes that you do in your implant position in the apical coronal direction or in the buccal lingual direction is gonna dictate your emergence profile. And if you place, for example, that too shallow or too buccal, you might need to work with a very flat contour of your provisional, and you can push the soft tissue and have further mucosal recession. Okay, so this is really tricky and very sensitive, the implant position in those cases. The literature is going to show us that if we place the implant with a platform very facially, very buccally, we have a odds ratio up to 17 times to develop a mucosal recession and then compromise our outcome. But sometimes it's not really so easy to place our implant exactly in the position we want to. And I really like this publication by Dr. Joseph Kahn from California, from Loma Linda, where he discussed the different socket shapes and the sagittal root position of the tooth in the socket, that it's going to dictate if your immediate implant is more favorable if it's more technique sensitive or if it's not recommended. So let's move on. I place some implants here just as an illustration for us to understand this classification. So when our tooth on the figure 1 here is on the sagittal root position against the buccal plate, it's the most favorable kind of socket to place the implant immediately. Why? Because you have all the lingual plate to engage your implant and give you primary stability. And you can place your implant in a position that you are away from the buccal plate. So you have room for your emergence profile of the crown, and you have a gap to place bone grafting or soft tissue grafting, or both sometimes, and then increase the thick of this buccal plate in order to reduce the bone remodeling and the bone resorption. On the class 2 and class 3, it's more technique sensitive. It's harder to achieve primary stability because, for example, on the class 3, where the tooth is engaging the lingual plate, in order to place your immediate implant, you're not going to have much bone on the lingual side giving you primary stability. You're going to be dependent much more on the apical bone, which we usually recommend to have at least 4 millimeters of apical bone after the socket in order to give you some good primary stability for your implant. And on class 4, where the tooth is really in the center of the ridge, and the ridge in the apical area narrows down like a funnel, it's really not recommended because you're not going to place your implant in the right position, and you're going to have a very hard time to achieve primary stability. Also, this nice study done here in Michigan by our colleagues, and Dr. Mendonça is one of the co-authors of this paper. They did a cadaver study, and I'm representing here with one of my clinical cases. Most of the times that we are placing an immediate implant, the implant tends to move facially. So in this study, they compared implants placed in the extraction socket free-handed and used computer-guided surgery. But in the computer-guided group, they used a semi-guided protocol. So they use a guide to drill the implant bed, but they place the implant itself free-handed. And then in those cases, the implant tends to move a little bit facially because the implant is going to move the path to the pathway with the least resistance. So you have the lingual plate, you don't have a buccal plate there because you're going to have the gap, so the implant tends to move facially. And you have to be very cautious with that in order to not compromise your implant position. So sometimes it happens that we plan an implant like this in the cingulum position for a screw retain restoration, and we end up with the implant moving facially, and we end up having to do a cement retain restoration. Another important factor to consider, and it's very related also to implant position and the avoidance of having the implant too facially, is the diameter of the implant. We are lucky today that we can work with implants of 3.3 millimeters, 3.5, sometimes 3.7 or 3.75. That can give us a very good outcome with very few chances for fracture, for example. And it's going to be much better for the size of the socket. We have studies showing the size buccal lingual of a central incisor, lateral incisor, or a canine. And in most of the times, you should not go for an implant larger than 4 millimeters, and really need to avoid 5 millimeter implants, because the larger your implant, the less gap you're going to have with the buccal plate, and closer to the buccal plate you're going to be, okay? And not only to consider the mesial-distal distance. So this gap between the implant and the bone that I have mentioned many times before, it's really important. And this is a concept that started back in 2003, 2004 with Botticelli, and Dr. Joseph Kahn and his group from Loma Linda had a series of publications on that, showing that possibly grafting the socket around the implant could minimize the horizontal bone remodeling. And we actually know that from the literature that even if you graft, you're not going to avoid completely the bundle bone resorption, because this buccal bone that is usually very thin is dependent on the sharper fibers from the periodontal ligament. So the periodontal ligament of the tooth is inserted in this bone, and once we do the extraction and we remove the periodontal ligament, this bone really tends to resort. However, if we place a bone grafting between the implant and the buccal plate, between the implant and the soft tissue, we can minimize this, and we can minimize especially the collapse of the soft tissue into the socket space. And by doing that, we can preserve some space, and we can probably preserve some buccal plate, or we can reconstruct the buccal plate in many times. Many authors would advocate for this term instead of preserving the buccal plate that is usually restored. And as I showed you in a study before using CBCT, the thicker the buccal plate, the less remodeling we're going to have, either vertical or in a horizontal dimension, okay? So this is how we usually do our cases for the last 9 years that I have been working with this approach. So this is a patient that had a failing central maxillary incisor on the right one, the number 8. You can see an internal root resorption here. So the tooth was extracted and the implant was placed immediately. Then we grafted the socket with in this case was a bovine bone by us, and we perform an immediate provisional crown. Then this is the outcome 6 months after the immediate implant placement and the provisionalization. Here, 6 months after, then we remove the provisional crown, and then the patient will undergo the prosthetic rehabilitation, impression, and then delivery of the final crown. And this is then the final crown, a radiographic control. At this time, we can still see probably the bone particles around this abutment, around the implants. This is an approach that I like a lot as well, which is called one abutment, one time. I know that Dr. George yesterday showed the customized healing abutments, the customized prosthetic abutments, and how important those customized abutments are to give really a good shape for the abutment. However, the stock abutments has this advantage that you place it one time, you torque it, the biological width will be established, and you don't change it anymore. So we really see that as a good option in many cases, and a very good behavior of the peri-implant tissues. So this is initial 6 months, and then this is the patient initial and after the final crown was delivered. And this is a control of 4 years. 4 years later, we can still see the mid-facial margin, papilla height, and crestal bone levels very well preserved. Another factor that is really important, and I mentioned a little bit about before, is the tissue phenotype. And now I'm going to show you different possibilities that we have to identify the tissue phenotype before we go for the tooth extraction and the implant placement. So this is a very interesting article published in 2008 by a friend of us, Dr. Januario from Brazil, where he did a very simple but effective thing and got this publication. He used a retractor to retract the lips, and then the patient has the CBCT taken using this retractor. In this way, by retracting the lip, you can see the buccal plate, and you can also see the soft tissue, and you can measure the soft tissue on the CBCT, for example, or any CBCT software. In the Blue Sky, for example, as Dr. Mendonça showed before, it's a free software. And that is my approach when I do those cases. So I usually take an intraoral scan of the patient. You can see here the outline of the STL of the intraoral scan in green. We have then the CBCT with the lip retracted, and then we align those two images in the software. By aligning those two images in the software, I have the opportunity, if the patient is missing the crown already, like in this case, I have the opportunity to do a digital wax up. And now by having my tissue thickness, CBCT, and where my future crown is going to go, I can place the implant in really the ideal position. And by doing that and generating a guide, I will improve, I will optimize my workflow in a way that I most likely will obtain an ideal implant position using guided surgery, for example. And here we can measure the soft tissue thickness, 1.43, 1.38, for example, here, by retracting the lip, as I showed you. Of course, that there are many ways to look at patient tissue phenotype. Using a probe, for example, it's a very simple and cheap way and can give us a good outcome. Dr. Khan in 2010 published the reliability of using a periodontal probe in the sulcus. And if you can see the probe, most likely you have a thin tissue. If you cannot see the probe, most likely you have a thick tissue. Also, we have the ultrasound methods. It's something new. It's a non-invasive method. And we have a lot of research going on here in Michigan by the leadership of Dr. Chen. And that's a new perspective for the future. And by looking at the tissue phenotype, for example, if you are dealing with a very thin tissue, we can improve the quality of those tissues. We can also change the phenotype from a thin to a thick during the surgery by adding a connective tissue graft. And if we look at the publications on connective tissue graft, most of them are showing a very good outcomes. This one, for example, was really one of the first randomized clinical trials on this aspect, showing that the mean facial soft tissue change for the control group was minus 0.7, and in the CTG group, in the connective tissue group, minus 0.2. Another two very recent articles published in 2018 show that maybe by adding the soft tissue at the same time, you are not going to control all the horizontal remodeling that happens, but the connective tissue graft really leads to less midfacial recession. So by adding the tissue and turning your tissue into a thicker one, this tissue tends to be more stable and you have less recession over time. And this is how we usually do. This is a very nice case I want to share with you, done by a very nice surgeon, very good surgeon from Brazil, Dr. Marcelo Nunes, a friend of us. So Dr. Marcelo was replacing this failing lateral, upper left lateral incisor, as you can see. Just by looking, you can see that it's a thin tissue phenotype. This is the X-ray. This is the CBCT. And then he performed a minimally invasive tooth extraction using an extractor device, which we like a lot to use. And I have been using in most of my cases when I'm extracting tooth in the anterior area, especially between K9 to K9. So this is the drilling protocol that was performed. I'm going to advance a little bit the video because of time. And then in this case, Dr. Marcelo actually opted for using a zirconia implant. It's something that I don't have much experience with, but it has been shown that it can be a alternative option, especially when we are dealing with those very static cases, especially when we are dealing with thin phenotypes. So you have the white of the zirconia as a very aesthetic material, right? So implant was placed more palatable, like we mentioned before, and now we then have a gap, and this gap will be filled with a bone grafting, and also a soft tissue grafting was done in this case to improve the tissue quality, the tissue phenotype, which was very thin. We are going to transform that in a thicker tissue. So this is the provisional crown being fabricated. And then once we do the pickup of this acrylic component that go over the implant, we're going to finalize the emergence profile. We're going to talk a little bit about the emergence profile later on. And this is a good technique to do the provisional. However, in many of those cases, if you don't have the emergence profile pre-established before you're going to the surgery, it's sometimes challenging to really give the ideal emergence profile you have, because the tissues really tend to collapse during the surgery. So you extract the tooth, you're placing the implant, the tissues tend to collapse. Here, a soft tissue grafting is being removed from the palate. I'm going to go a little quicker on that. The dermoabrasion technique was used, so we remove the epithelium with a burr, and then we harvest only the connective tissue then from the palate in this case. So here is the tissue being removed. And then we are going to prepare the area to receive this tissue using like tunneling instruments. It's more like a tunneling procedure. We open some room for the graft, and then this graft is sutured over under this area and extending to the papilla area. So we don't need a very big graft in the apical corona direction. We need really the first 4 or 5 millimeters. That's where the most of the changes is going to happen. But we like to extend to the papilla area to give some support to the papilla. So this is what is being done with these sutures. We first suture one side, then the other side. And a lot of people only do these 2 sutures. Some people like to do some sort of coronally advanced flap or some extra sutures at the final of the procedure in the papilla area. So now here we are placing our bone grafting between the implant and the buccal plate. So once this bone grafting is placed, we can then cement the provisional. Here's the provisional being tested. Okay. If everything is fine, now you can see here, bone grafting, soft tissue grafting, and then the provisional is cemented, and we are going to perform another 2 sutures to bring the tissue a little bit coronally, but more to stabilize the tissues in the papilla area. Here's the outcome right after. And then a few months after the surgery, the tissues healed. We have the radiographs 30 and 60 days after the implant placement. And now we have a very thick tissue in the buccal side, and the final crown was then delivered to this patient. So here how it was started and how the case was finalized. We then have a follow-up of 4 years for this case, a really beautiful procedure done by Dr. Marcelo. And crestal bone levels very stable, soft tissues very stable, and patient happy with the outcome. Last aspect that I would like to talk to you about is the restorative considerations. So how we are going to perform our immediate provisionalization, why it's important. Actually, we can place the immediate implant and just place a healing abutment on top of it, or we can also place a cover screw and suture everything. But in many times, we want to condition the soft tissue during the healing process. We can then shorten the treatment time, and we can provide immediate aesthetics for the patient, right? If we go to the literature, I don't recall any study that really proved that it is really better to do a immediate provisionalization in terms of the final outcome. But the study that are closest to these findings is the one done here in Michigan by my colleagues and faculty, where they perform a randomized clinical trial, is exploring immediate implant placed, and then they did a group with a provisionalization, this group in the left, and the other group, the control group, they used a healing abutment. And then they concluded that the immediate provisionalization did not show better aesthetic outcomes than using a flared healing abutment. However, when I look at their radiographs and their photos in the publication, what do we see? We see that the healing abutment gives, probably in most of the cases, because they use a flared one and a larger diameter, the healing abutment here, in this case, for example, is giving a very similar soft tissue support than my provisional crown would give. So it's not like a fair comparison, and they were very responsible in their conclusion by stating that immediate provisionalization didn't show better aesthetic outcome compared with the flare healing abutment. But we really need a study in the literature that compares that immediate provisionalization with a cover screw being placed on top, completely closure of the tissues, and then crowns on a second stage few months after. So we can't really conclude on that. In our experience, we do like to perform provisionalization when indicated, when we have good primary stability, when we can educate the patient, when we can really take this provisional out of occlusion and be safe with the approach. A very important thing when fabricating our provisional is to look at the critical and the subcritical contour. This is a very classical publication by Sue in 2011 in the RJPRD, when they talk about the critical contour, which is the first millimeter of the provisional crown that it will be in contact with the gingival margin, with the mucosal margin. And then the subcritical contour, which is after the critical contour in the apical direction. And this subcritical contour has to give a runny room and some soft tissue volume. So if we do, like in this case here on the green outline, a over-contoured crown, we might push the soft tissue up and we might have mucosal recession. If we do it flat, we might compromise or not the soft tissue margin. It's going to depend a lot on the tissue phenotype. But if we do under contoured, following the red outline, we are going to have more space for the soft tissue during this healing process, and we're going to have an increased soft tissue thickness, and then you're going to be less prone to mucosal recession. Another publication by Testori showing that this convergent instead of a divergent abutment, it's better because we're going to have more tissue volume in this case. And this is what I really like. So I'm going to play this little video again, just to show that when we are too shallow with our implant, we're going to have a flat subcritical contour because we are not going to have height, running room to work your emergence profile. So we need to be really careful with the implant position. It slightly changes the implant position is going to dictate your crown shape and your emergence profile, your crown contours, okay? So that's why I like to work 4 millimeters in the apical coronal direction. It's going to have a direct impact in my provisional. So the provisionals has some advantages, of course. We can maintain the soft tissue profile. We can protect the blood clot that's going to be in the area, protecting our bone grafting particles that we are placing there. We provide immediate statics to our patients. We can possibly have less midfacial recession if we work properly and reduce the treatment time. But at the same time, it's really technique sensitive, and the controlling of the occlusion, as I mentioned before, is a key on this modality. So there are many ways to fabricate an ideal provisional, many techniques. It really depends on your preference, on your logistics, and on your skills. I'm going to share with you just really quick two ways of doing the provisional two ways that we like to do it. One would be the autogenous extracted tooth technique. It's a really nice technique because the patient really loves it. It's a little technique sensitive, but when we extract the tooth and place the implant and we can maintain the tooth, see the palatal position here, a stock abutment being used. This is the final implant position. So when we can maintain this tooth, like in this case that had a calcified canal, we just we just cut this crown at the level of the root, of the cervical portion of the root. And then we hollowed this tooth, and then we used just some like regular conditioning and bonding and flow resin to capture this abutment in the mouth. And once we capture it, we do the pickup of the abutment, we are going to work the emergence profile. And as I mentioned by Shu before, we work first in the critical contour, which is the first millimeter that will seal the border of your crown with the mucosal margin. And then after this critical contour, we work very concave, giving running room for the soft tissue. So the more concave this area is, more soft tissue we're gonna have. Then here just using the bone graft to fill the socket. This is then the provisional crown using the patient's tooth done. And here we did a screw retain one. And this is how the patient goes home right after the surgery. This is the final photo. I have a follow-up of 3 days of this case, and then 30 days later, and I couldn't have a chance to follow up further this patient since I moved to the US. And really the last technique that I would like to share with you is nowadays we have so many options with digital dentistry. And in the previous webinars of this series, we have seen really great presentations on digital dentistry, doing that in different ways. One of the ways that we do, and we did for this specifically case, and this technique is published in the Implant Dentistry last year, is extracting the tooth of the patient virtually and creating a 3D printed model. We print a model with the socket. So we have the tooth extracted, and we have the shape of the socket of the patient even before we go to the surgery. We do that on the CBCT, and then we print. Then going to the surgery with a guide. We were trying to prove this concept, so I marked with a pen the shape of the contour of the crown. And then after I extracted the tooth, we tested this tooth on the 3D printed model, and it was really matching exactly the situation I had in the surgery. Then we place our implant on patient's mouth, and we can transfer this position by using an impression copying to the 3D printed model. So we transfer that to the 3D printed model using an implant analog engage in this impression copying. And then what we're gonna have? We're gonna have exactly the same implant position we have in the mouth in the 3D printed model. And I can choose the abutment I'm gonna use in the 3D printed model. I can fabricate my provisional crown in the 3D printed model and just transfer it to the mouth. What is the advantage of that? You don't have to work with resin. You don't have to fabricate your crown in patient's mouth with blood, using like resin in areas you're gonna have a bone grafting or a soft tissue grafting. And if you are working with a multidisciplinary team, the surgeon can be doing the surgery and the prosthodontist can be working in the provisional crown pretty much almost simultaneously. And when the surgeon finishes the surgery, you have the crown to be cemented or to be screw retained, depend on the option you make. You can do both kind of protocols using this approach. So this is right immediately after the surgery. This is a few months later, the patient underwent a prosthetic rehabilitation, but the most important thing is the implant in the right position with crestal bone levels preserved. And here we have a little video with the CBCT cross sections. So we have at least of 1 millimeter of buccal bone plate after 18 months, which is really good. It's going to give us a long-term stable outcome. And then here's the patient happy after the rehabilitation she had, because she had a trauma when she fell from a bike in a Sunday riding. And this is pretty much all I had to discuss with you today. And be really aware of all the factors that can influence the tissue stability and really respect the biological principles in order to obtain the best outcome. I think this is the take-home message I would like to give today. And really thank you for your attention. I'm looking forward to answer any questions that you may have, and would like to thank you, Dr. Uvu, again for this great opportunity. This on the left-hand side is a beach close to my hometown where we used to spend some free time. And here on the right side is where we live now, the Michigan Stadium, in a game with our biggest rival, Ohio. That's it. Thank you so much.
All right. Thank you so much, Dr. Sequeira, for that wonderful, like I said, you guys are going to take me to Curitiba very soon. One of these days, you've got to take me there. Anyway, let's go back. I see some questions here. So what view of do you see the questions, Dr. Raphael?
Yes, of course.
So what view of the cone beam CT is best for monitoring osseointegration of implants?
Okay, what view is the best? I would say that I use pretty much all the views. So you can use the cross-section, the sagittal views, the tangential, and the axial views. Of course, that's the sagittal views, the cross-sections would be the best for us. However, we have a limitation with cone beam CT. We have to be careful. Not really only to look at osseointegration, but to identify if I really have bone surrounding the implant. There is a very recent publication showing that if you have 0.4 millimeters of bone around your implant, most likely you won't see it. If you have 0.7, from 0.4 to 0.3 of bone, you're gonna be probably in doubt if there is bone or not. You're gonna be really clear that there is bone surrounding your implant when you have more than 0.7 millimeters. Why that happens? Because you have a scattering, you have artifacts from the cone beam tomography when it hits the metal of the implant, which makes the diameter of the implant actually 12 to 15% larger than the implant actually is. And this is why a lot of research is being conducted on this field. And for example, here at the University of Michigan, we are using quite often the ultrasound to look at some implants that we are not really sure if there is a peri-implant disease or not, and we are not really sure if there is bone surrounding the implant or the threads are exposed.
Okay. So the next question from Jason Toledo from Brazil. He said, why in the case of the Protello you use 6 implants? You couldn't have used a technique of all-on-4?
Oh, okay, thank you. That's a good question. Thank you for the question, Jason. So this was not really the focus of the topic today. I was showing more like as an example where immediate occlusal loading is safer for full large reconstructions. You could use all-on-4. There is an indication for all-on-4, but sometimes there is an indication as well to over-engineering, to use more implants than 4. When I'm gonna do it, especially when I have a younger patient, if I have available bone to place 6 implants in ideal position, I would prefer to place it without compromising the implants being too close. So if I have good availability, I can distribute my implants in a good way, no financial restrictions, and depends on the material of the prosthesis I'm gonna use on top, I would sometimes choose to place more than 4 implants. However, the all-on-4 technique can also be indicated for some patients.
Okay. Another question from Dr. Abiodun Adebayo. He says, how is stress related to implant failure, either immediate or delay implant placement?
Stress like traveling on road for long hours or fever. So to be honest, I don't know much literature on that. When we talk about a stress, for osseointegration itself and for implant failure, we are talking about stress in terms of masticatory forces, occlusal loading, and the possibility of micro movements of the implant in the bone. So I don't think this would be a problem, the long hours of traveling. Of course, the fever and all that has an impact in the systemic aspect that can compromise the bone healing, but I don't think that would go for a point that would compromise osseointegration if properly done and if the occlusal forces are controlled.
Okay. All right. Thank you so much. I really appreciate it. Thank you, Dr. Sequeira, Dr. Mendoza.
Thank you, Dr. Uvo. It was
Sure.
really great, this opportunity. Looking forward for the next webinars. I will try to attend as much as I can.
All right, thank you, thank you. We're going to have on the 26th of June, the flyer is not out yet. We're going to have, I need you to respond to me if you don't mind, please. It's going to be a dentistry during COVID-19, but we want to take questions. There's going to be a presentation by Dr. El Brashi. He has done this presentation severally for Neodent, for Nobel, for Dentsply, you know, and he wants to do it for us, and that's a really good one, you know. So I want you to, if you have, he wants to respond to questions. So what questions do you have concerning dentistry during or post COVID-19? What do you, I want to respond to your questions. So I've put my email address on the chat. I need you to send me an email with a question so that you can have a presentation addressing, you know, specific questions from folks who will be on the webinar. It's going to be on the 26th. It's going to be on a Friday. It's a little different from what we have. So we're going to have it there on a Friday at 10 a.m. Eastern, which is I think 3 p.m. West African time. So if you have that, please send your questions, email me, so that we can tailor that webinar to answering questions that you might have concerning aerosols, concerning PPE, concerning just the microbiology and all the things that we need to do, engineering controls. What are we going to do? How are we going to get back to work? How are we going to get back to normal? So my email address is there, onoriobe@umich.edu. This topic is coming up. It's going to be on the 26th of June. And looking forward to having you next weekend. Thank you so much for joining us. And I'm just going to wait on here for a few minutes for you to get my email address and send me a note. If you have something to say, you can go ahead. If not, I'll see you on Saturday next week. So on Saturday, this week, we're going to have Dr. Eva Baldridge. We'll be talking about implant team building. She's a maxillofacial prosthodontist from Houston, Texas. And we're also going to have Dr. Eva Anandioti. She's the director of the prosthodontic graduate program at University of Pennsylvania. It's really, really cool to have two Dr. Evers, very brilliant ladies, and they'll be presenting next week on Saturday. And on the 27th, we're going to have Losing Sleep Over Obstructive Sleep Apnea with Dr. Annie Press, and Dr. Alvin Wee will be presenting on implant-supported fixed dentures. Dr. Alvin Wee is the director of the prosthodontic division at the University of Minnesota. We have been so blessed having folks who are leading programs, and it gives us an opportunity to interact with them. For students who want to do postgrad programs, this is your best bet. We are going to have in the next 2 weeks program directors of this program, of this specialty coming on here, and it will be awesome to just have an opportunity to interact with them. Anyway, I'll see you next week. These videos are going to be uploaded on YouTube later today or tomorrow. We have the one from yesterday, Doctor. If you want, if you attended yesterday and you wanted a slide, Dr. Sri Koka has been gracious enough to send us a copy of the slide of where does the rock go when the rock needs help. That is a very powerful. The video is already up on the website. on the YouTube channel. Go there, subscribe, and let's let me see if somebody had something to say. All right, so you guys take care. I'll see you next week.
Thank you, Dr. Uvo. Take care.
Okay, then. Bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator